Welcome to this session, Experimental Therapies for Ovarian Cancer. We'd like to thank Alkermes for making this session possible. It's exciting to learn about the progress being made in gynecologic cancer research, but the terminology used can be very confusing, and it's hard to know how some of these concepts are related or differ from each other. Dr. Kathleen Moore is here to help demystify this. Dr. Moore holds an endowed chair in developmental therapeutics and is a professor of gynecologic oncology in the Department of Obstetrics and Gynecology at the University of Oklahoma Health Sciences Center, where she holds a number of additional leadership positions. Thank you for joining us, Dr. Moore.
Hello, everyone. Welcome to this on-demand session. Today, I'm going to be talking about really what we call developmental therapeutics in ovarian cancer. And I'm going to focus predominantly on recurrent ovarian cancer, which is where we develop new therapies and then move them up. So the title of my talk is Novel Combinations, Biomarkers, and I'm going to talk a little bit about immune modulators in recurrent ovarian cancer. I work with a lot of drug companies in my job here at the Stevenson Cancer Center. So these are my disclosures of all the drug companies with whom I work. And so let's just give a general overview of the problem of ovarian cancer, which you all are living, and so you're well aware, but just globally, so you get a sense of what we're dealing with. This looks like a big number. It's about 300,000 new cases diagnosed in 2020 globally, which sounds like a big number, but compared to breast cancer and lung cancer and colorectal cancer, prostate, it's not, which is some of the challenges in drug development is that we just don't have as big a population, but top of mind and most important to us. So 300,000 new cases, and despite a lot of ongoing work on very recent work trying to screen and prevent ovarian cancer, we still can't do that. And so the majority of patients who are diagnosed with ovarian cancer have advanced disease. And we are curing more, which I'll tell you about, but the truth is that the majority of patients who are diagnosed with advanced disease will recur. And once recurred, we have many things in development, and I'll tell you about them, that do prolong overall survival. So we are cobbling together longer survival than ever before, but it's sort of survival on treatment and not just one treatment and cure, which is our goal until we can prevent. And we still have just far too many people dying of ovarian cancer. So this is a significant unmet need for us and those of us that work in this space to really get it in the front line. So this is just a figure that I like to show that just kind of shows a little bit of what we're up against. And it starts on the left-hand side. This is at diagnosis. Patients typically present with a lot of disease, a lot of cancer in their abdomen, sometimes spread to fluid in the lung, less frequently disease in the liver, but it can happen. The blood marker, which is CA-125, usually is very elevated, but not always. And so patients present. Now, when we're talking about high-grade serous ovarian cancer, which is the most common, these tumors tend to be exquisitely sensitive to platinum-based chemo. Carboplatin is what platinum-based is. So with the combination of chemotherapy and surgery for probably about 80% of patients, we end that first 6 cycles or 8 cycles of chemotherapy with a CT scan or PET that looks normal. The CA-125 blood marker has returned to normal. And for all intents and purposes, it looks like everything is gone. But we know from the olden days when we used to reoperate on everyone that even in that setting, we will find cells of cancer in about half. So that led to this idea of maintenance therapy, which is now what we employ. And I'll show you that in a moment to try and really push out the time until the next recurrence. Once recurred, either by symptoms or imaging or CA-125, we have a variety of medicines that we use, and we'll talk about this a little bit. But with each recurrence and each progression, the patient will start with more tumor than the last time. and kind of residual toxicity from each line of therapy, until such time that there's just more tumor than any therapy can be expected to control. And that's kind of when we lose control of the disease. And so if we're going to really change this meaningfully, we have to screen and prevent. That's the most important thing. And we're working on that. But until then, we got to cure more patients in the front line. And so that's really what we're striving to do. And we do see signals of this with PARP inhibitors. So what's a PARP inhibitor? PARP inhibitors are oral, so they're pills. They're taken every day. And PARP is poly-ADP ribose polymerase. You don't have to remember that. It's at the bottom of the screen. It's a protein, though, that is part of the very complex system of proteins that fix DNA errors. When our normal cells are dividing, as they do, lots of errors are made. Just happens. It's really complex. So errors are made, and we have elaborate surveillance of replication that fixes these errors so that the cells that divide and grow, like skin cells or cells of your colon, things that are rapidly growing, kind of cell growth and overturning cells, are normal. So it's really good for a normal cell to be really good at fixing its DNA. You want that. It's not good for a cancer cell to be really good at fixing its DNA. Cancer cells, because cancers grow fast, they're kind of under pressure because they're growing so fast, their DNA is replicating quickly so it can kind of keep dividing and growing, that they make a lot more errors in how they replicate their DNA. The same proteins that fix DNA in normal cells can be present in tumor cells, but not all. And it's common in ovarian cancer for there to be missing proteins in that sort of surveillance system of how the tumor is surveying its DNA to fix things so it can keep growing. So it has what we call an inherent vulnerability to how it's fixing its DNA, like it's barely hanging on. So if you block key components of the DNA pathway, and PARP is one of those. PARP is a protein that fixes DNA. So if I take that out by blocking it with a PARP inhibitor in a cell that already struggles to fix its DNA, like a cell with a BRCA mutation. BRCA is the key protein to fix DNA breaks. So a BRCA mutation, you've lost that key protein, and that cell is relying on PARP. So now I've blocked PARP, and it can't fix its DNA, and it dies. There are other reasons why a cell that doesn't have BRCA would still have that vulnerability. So when you give a PARP, it similarly is sort of synergistic, and the cell will die. So this is a schematic you can see here on the upper left. You can see the little error in that double-strand DNA break. There's a what we call a single-strand break. PARP is there. The purple is a PARP protein. It's come in, sticks to the break like gum, and tries to fix it. And it calls in a lot of friends and other proteins to help fix that DNA. A PARP inhibitor, which is the orange little blob, sticks on the PARP protein and prevents it from doing its job. That leads to further errors. You can see that on the right-hand side of the screen at the top, where the break gets bigger. So now the break is bigger, and that what we call that replication fork, where the little complex is moving along and fixing DNA and replicating it, gets stuck. And in a cell that has no other compensatory way to fix that glom that you see there, so we call that homologous recombination deficiency, or HRD. You can see that in the lower left. BRCA, there's other things that make a cell already inherently kind of struggling to fix its DNA. In that setting, that cell will die. In a cell that has really intact function at how it's going to fix its DNA, blocking a PARP just doesn't matter. So those are normal. You won't see any benefit. So that's where kind of you see this differentiation in where PARP works and where it doesn't work. Some cells are just very resistant to PARP, but we're working on that. So when we use PARP inhibitor in tumors that are biomarker selected, like those with BRCA, we see sort of what we think are transformational responses. So what I'm showing you here is what's called a Kaplan-Meier curve. This is from SOLO 1. So SOLO 1 was a clinical trial that was done in 2013, 2014. It resulted in 2018, and we continue to follow the patients on this study. These were patients who were newly diagnosed with ovary cancer. They all had a BRCA mutation, and they responded to their chemo. They got surgery and paclitaxel and carboplatin. Then they were randomized to receive a PARP inhibitor, in this case, olaparib. There are several PARP inhibitors that are approved, versus placebo, which sounds terrible now, I bet to you. But in 2013, there wasn't maintenance. Patients got 6 cycles of chemo or 8 cycles, and then we followed them. So it wasn't such a thing to use this. Now you're like, placebo. But this is the standard of care then, was nothing. So it's PARP versus nothing for 2 years. And then it was stopped. Whatever you were assigned to was stopped. So what you can see here is the follow-up out to 7 years. So this was presented last year. We're now 8 years. But at 7 years, of the patients who were randomized to placebo, 20% of them never recurred. So that's probably, for BRCA, our cure rate with chemo alone, 20%. With a PARP inhibitor, that increases to 45%. So we rescue about 25% more with a PARP inhibitor. And some of these patients will suffer late recurrences, but most of them should be in what we call the cure fraction. Once we get out to 10 years, you can still see random recurrences, but in general, we think patients are cured. And so this is really what we want. So we celebrate this. In the same breath, I will say, 20% of patients on this clinical trial, all who had BRCA and all the things, recurred while they were getting the PARP in that first 2 years, and another 35% progressed after. So we still have a lot of work to do, is the bottom line. We're not done here, but we did accomplish something here in moving more women into cure, and that's exciting. So just to tell you, we are getting there. And we aim to get there in more patients. But right now, this is kind of the best we've done. So worth celebrating, but more work to do. So when we are using our best agents up front, which we're using chemo and we're using PARP inhibitors. And sometimes we add in the medicine, you know it as Avastin. It's called bevacizumab. It's a drug that blocks how tumors make blood vessels for themselves. When we're using all of those up front, hopefully more people are cured, but the majority of people, even in SOLO 1, 45% haven't recurred, 55% have. So what do we do then? If I've used all my good drugs up front, what do I do when people get here? Well, kind of depends on what people received at their first therapy or their last line of therapy. If somebody had already received a PARP inhibitor, but had not received bevacizumab, which is Avastin, then we would use bevacizumab with chemo and as maintenance. If they received prior bevacizumab with their first chemo, maybe they were treated before PARP became approved, and they hadn't received a PARP, then we would use a PARP inhibitor, but only in settings of BRCA in the recurrent setting. PARP inhibitors are no longer approved for any tumor other than BRCA in the recurrent setting. So a lot of room we have to develop there. If you receive both in the front line, which is what I do, I use both PARP and bevacizumab, I can reuse bevacizumab. I can reuse a PARP in certain settings, but this is really where clinical trials are very important in developing new medicines. So in the recurrent setting, in a person whose tumor has not progressed or recurred within 6 months of their first or their last platinum, could be your first platinum or could be your second platinum, carboplatin. But if you have not recurred within 6 months of receiving that last dose, then we reuse platinum, carboplatin, or cisplatin, usually with a different partner. And that partner could be gemcitabine, which we abbreviate GEM, or it could be pegylated liposomal doxorubicin, PLD, which you might know as Doxil. Sometimes we reuse carboplatin and paclitaxel too. It actually works again, but we try to use other things just because of the hair loss and neuropathy. All of these medicines work better with bevacizumab, which is abbreviated as Bev. So when it's not contraindicated because of really high blood pressure or history of blood clots or a non-healing wound, those are the reasons you cannot use bevacizumab. We use this in the recurrent setting. So this would be the standard of care. The first indications for PARP inhibitors before frontline, which is where we use them now, were in this platinum-sensitive recurrent setting in patients who get another platinum and the tumor responds again. Then they were randomized to PARP versus placebo, just like that first study I showed you, but these were done in the recurrent setting. And this is really where PARPs really first demonstrated their efficacy, not just in BRCA, but in really any tumor that responded to platinum. So you could be BRCA benefited the most, but even non-BRCA benefited. So you might say, well, why is that? Well, in a tumor that shrinks when it gets platinum, carboplatin works by damaging DNA. That's how it works. So if the tumor responded to that, that tells you that that tumor struggles to fix its DNA. Because if it could fix its DNA well, it wouldn't be impacted by carboplatin. The fact that carboplatin made it shrink tells you that it struggles to fix its DNA. So that's kind of a clinical biomarker for benefit from PARP inhibitor. So the initial indications for PARP inhibitors were in all comers in the recurrent setting. We could use it BRCA, non-BRCA. All of those indications have been taken away from us by the FDA. And so now we're only left with use of PARP inhibitor here in BRCA-associated cancers. And most patients are getting it in frontline now. So, what we do with this indication is a little up in the air right now, unless someone sort of missed the opportunity to get a PARP in the frontline and they have a BRCA mutation, then we're for sure using it in this line of therapy. And I'm treating someone like that right now. She recurred 10 years later after her first treatment. She's BRCA2. And so she's about to start a PARP. So that's really kind of the only place we're using PARP inhibitors in the recurrent setting right now. So what I'm going to talk about I just wanted to set the stage. So what I'm going to talk about for the rest of this time is sort of what the definitions are for kind of recurrence and resistance and expectations for standard of care, meaning like what's available, and then what interesting new molecules are available and kind of what they mean from a mechanistic standpoint. So at some point, once tumors recur, they become what we say platinum resistant, meaning that they either grew during platinum, like say someone recurred and then responded to platinum and then recurred again and got another platinum, and then the tumor didn't respond that time, or it grew during that platinum. We would say that tumor is resistant to platinum. And disease that recurs within 6 months of the last platinum, we would refer as resistant to platinum. Now, those aren't necessarily exactly the same tumors. You can probably imagine a tumor that grows on platinum versus a tumor that maybe responded and then you stop the platinum and it grew back like 3 or 4 months later. Those are different, kind of in terms of how they behave, but historically we've kind of lumped them all together and called them platinum resistant, and our clinical trials have been kind of founded on that definition. It's changing though, and I'm going to give you some examples of where that's changing. Once tumors become resistant to platinum, we struggle to control them. And that's just the unfortunate reality. We have decreasing expectations of medicines, current medicines, really causing disease to shrink in a large number of patients. And even if they do, the duration of time over which they hold that control gets shorter and shorter with each line of therapy. So our biggest opportunity is to kind of prevent tumors from recurring, number one, and becoming resistant, number two. But this is really where we develop a lot of our new drugs, because if it works here in this sort of resistant setting, we have an even higher expectation that it's going to work better in a platinum sensitive recurrent setting or even in the front line. So that's why we test a lot of our new medicines in this platinum-resistant space where there's just there's increasing, but not a lot of great standard of care options. And the standard of care options are mostly monotherapy chemo. I'm going to show you a little bit of different data in a moment, but this is just a chart that shows very recent clinical trials in the platinum-resistant space, and the control arm, meaning the standard of care arm, was Doxil or paclitaxel or gemcitabine or topotecan. And the response rate, which is response in a clinical trial, means that the sum of tumors on each patient shrinks by at least 30% or more. That's a clinical trial definition. And I'll show you an example of that in a minute. But the response rate on these for standard of care chemo is quite low, like at best about 13% for this cumulative data. And the disease control rate or percent time on average is just under 4 months. So we just don't like to use these medicines if we can avoid it, and we like to use more active things. That's why we're really trying to develop in this space. When physicians look to see sort of what's available in this space for recurrent disease, they typically will go to something called the NCCN, or the National Comprehensive Cancer Network, which gives a list of medicines that either have FDA approval or enough data to justify being on this list so that insurance will pay for it, which is really the reason the NCCN exists. And so these are the chemos that are listed for platinum-resistant disease. And then for targeted therapy, again, you'll see bevacizumab there, or Avastin. And the new agent, of course, is mirvetuximab or Elahere. For the first platinum-resistant recurrence, we tend to use chemo plus bevacizumab, unless someone's had bevacizumab before and didn't tolerate it. But we tend to use it again, either with paclitaxel, Doxil, or topotecan. And I even use it with gemcitabine, even though it wasn't a part of this trial. It certainly works just as well. Bevacizumab makes chemo work better. It does come with side effects such as high blood pressure. It can increase the risk for blood clots. And for patients who have a lot of involvement of their intestines, it can have a much higher risk for causing a hole in the intestines. So we do have to be careful in the recurrent setting in selecting the right patients to get bevacizumab, because we definitely don't want to cause harm. But for patients who are eligible, which is a lot of patients, maybe 60%, it does improve the rate of disease control. And you can see that in the Kaplan-Meier curve at the top, where the teal line are the patients that got bevacizumab with their chemo, and the gray line is the patients that got just chemo. So the kind of the farther up those lines are, the better the patients do. So this is the standard of care. And we do want patients to have access to this kind of before they come on to clinical trials. Once someone has seen this, then we have that kind of list of things that don't work very well. So high unmet need for new and better medicines. So the first drug that was approved in the last decade in this setting is mirvetuximab or Elahere. I'm going to show you a figure for how this works in a moment. But this is already FDA approved, so I'm including it here. It was approved in November of 2022. It's an antibody drug conjugate that targets folate receptors on the surface of cancer cells, and it delivers a highly potent molecule of chemo. So it's still chemo. It's just directed chemo, highly potent chemo, just to the cancer cell. So that's sort of how these work. And I have a figure to show you how these work in a few slides. And it works much better than single agent chemo alone. The response rate here, remember I told you it was about 13%. With regular chemo, it's 32% here. And all of these patients had to have had prior bevacizumab to come on the study. And the duration of response amongst responders was about 7 months. So is it perfect? No. Is it much better than standard of care chemo? Yes. So that's why it received what's called accelerated approval last year. The confirmatory trial to get it full approval was Mirasol, which we just presented this year in June at ASCO. And it's what we have to do to get drugs approved. This is called a randomized phase 3 trial, where you take a population that has folate receptors and you give half of them Elahere or mirvetuximab, and the other half gets standard of care chemo, which again sounds sad, but I'm going to show you some examples where it's not. And then you look at how people do. And on this medication, on this clinical trial, for progression-free survival, which is the time until the patient progresses on whatever therapy, here's the patients who got chemo, and then here's the patients who got Elahere. And this is what we see a lot in platinum-resistant tumors, in that how you read this is that these are months, so at about 6 weeks, which is the first CAT scan, we CAT scan every 3 weeks, half of the patients had progressed who got standard chemo. And this is what we see with these medicines and why we really strive to do trials and improve upon this. We don't see that bump down with Elahere. So the curves separate early and the patients continue to do better throughout the time on this clinical trial. And it reduced the risk of recurrence by about 35%. This is what I wanted to show you just to clarify what I mean by response rate. So on the left-hand side, this is called a waterfall plot. So you see why it looks like a waterfall. The bigger the waterfall, the better the drug works. So a bigger waterfall means that most of the lines, which is each one of these lines is a patient, is going down, means their tumor volume is going down. And the longer that line is, the better. So the bigger the waterfall and the deeper the waterfall, the better the drug works. Response rate is this dotted line. So that means that when a patient comes on the study, everyone starts at like a zeroed out point, and we add up all their tumors. Maybe it's 10 centimeters, cumulatively. That to qualify as a response, that has to decrease by 30% or more. That's all of these patients, if you can see my cursor. But these patients right here benefited too. So their tumor got, these patients, it was like 25% smaller. These patients, it was 20% smaller. These patients is 15% smaller. So any bit of decrease is good. So 80% of patients had tumor reduction, which is what we like to see. The other thing I will show you, though, because I told you those response rates for standard chemotherapy really look terrible. The things I showed you that were 13%. And when I show patients that in clinic, they understandably get very sad. They're like, why would I ever do any of that? That sounds terrible. But that's response rate. So that's this group over here. And it is true, even in this study, which I was the PI for, only 16% of the patients who got standard of care chemo responded by what we call clinical trial response. But all these patients had some benefit from their chemo. Their tumor shrank a little bit. So overall, 55% had some tumor reduction. So it's better with Elahere, but it's not like no benefit for standard of care chemo. So I don't want you to walk away from this going, well, I should never get standard of care chemo. It doesn't work. That's just the clinical trial term for response. 55% of patients benefited some, and that's not small. So that's why these drugs are available. But we want better than that. The other nice thing about Elahere is that we saw an improvement in overall survival, which we've actually never shown in the history of platinum-resistant ovarian cancer ever. And we did with this medicine. So here's the overall survival for the control group, and then here's Elahere with an early and sustained separation. So we reduced the risk of death by about 33%. Probably because this drug's so well tolerated, it worked, patients felt better, their bone marrow got a little better, they didn't feel as beat up, so they could probably go on to get other things. I think that's why we have better overall survival rather than just chemo after chemo after chemo. Eventually, patients just get beat down by that. So inserting these very active but different toxicity, it's not no toxicity, but different toxicity medicines can really help. So that's kind of some of the things that are available. Other things that are on the NCCN are listed here in pink. You see mirvetuximab. You can mix it with Avastin, bevacizumab, which is nice. That works quite well. And you can use that per NCCN. in tumors that are folate receptor alpha medium expressing, which I particularly like that because it works. The single agent is just for high. So this allows me to use the medication in more patients. But also you'll see in pink, things with carboplatin are highlighted. And you might be thinking, well, I thought you said we're talking about platinum-resistant disease tumors. Like, why are we talking about platinum? And actually, platinum remains a pretty effective regimen in this setting for patients whose tumors maybe shrunk on the last platinum and then it was stopped, because we do that. We give like 6 or 8 and then we stop. And then maybe it grew back in 5 months. Well, we call that platinum resistant. But if that's my patient, I'm going to just restart platinum because it worked last time and I'm probably just not going to stop it. I'm going to use it until it doesn't work. So we do reuse platinum. And why I'm telling you this is going to come up when we get to the immunology section. So stay tuned for that. But platinum is not an option for all patients with platinum-resistant disease. It's not, but it is an option for some. And so it's important to remember that. So when we're thinking about ways to improve, there's a lot of categories, but we're really thinking about antibody drug conjugates primarily, which I'll show you in a moment, immunotherapy, and then there's a lot of other things that we're thinking about too, other oral drugs that target how tumors fix their DNA, like Wee1 kinase inhibitors, ATR inhibitors, and then there's even other novel things, lots of things. But let's just talk about biomarkers and particularly antibody drug conjugates, because we really do try to individualize for patients. And I think that's going to help us identify better drugs for individual people, but it makes it hard to do clinical trials because I showed you ovarian cancer is not as common. And so if we start like narrowing down things into little niches, 10% of patients, 30% of patients, the trials get a little harder to do. And so we're trying to be very innovative right now in how we think about this so we can move more active drugs into the right patient at the right time. So biomarkers to us are very important. And so I'm going to talk about platinum-resistant biomarkers, but I always just have to start with BRCA when I'm talking with patients, because every patient should have been offered the opportunity to be tested for not just BRCA1 and 2, but the other, what we call high penetrance genes that not only predispose patients to getting cancer, but are predictive of benefit from PARP inhibitors and other things. And if we find them, we also can test family members. And if they have this mutation, we can try and do risk reducing strategies so that they don't get cancer. So if you have not been offered testing for BRCA1 and 2, please ask your doctor to do that because it's quite important. It's recommended by every single oncology agency internationally. There's no controversy about this. So hopefully everyone has been tested or offered testing. You don't have to take it. You can say no, but that should be your choice. It shouldn't be because of omission. But in the recurrent setting, we look for BRCA. We look for homologous recombination deficiency. I talked about that, but it's mainly a frontline kind of opportunity. We certainly look for markers for immune therapies like Keytruda or pembrolizumab. Those are really uncommon in ovary, but not never. So we look for them. We send testing for it. Increasingly, because of Elahere or mirvetuximab, we're looking for folate receptor alpha. In fact, that's been added to a lot of the panels that we send on your tumors. So we just know it. And then I know if this is on your menu or not, for the future. And we're also increasingly looking at HER2, which is a breast cancer protein. But there's new data, I'm going to show it to you, that shows that medicines targeting HER2 in ovary cancer work incredibly well. And so we are all starting to test for this as well as of about 3 months ago. So I'll show you why. There are a lot of clinical trials of studying recurrent ovary cancer. The bullseye is to get something FDA approved because we want it available to everybody, not just people who have access to clinical trials, but we want it available to everybody. So anything we do, we want to understand tumors, but we want to make sure we're doing things that are going to have some hope of getting some regulatory approval so that they help more than just people at clinical trial sites. But this is a hard space to work in. And until mirvetuximab, things have been negative. All of these are clinical trials. These 2 are gone. These 3 were negative. I'll show you those. because when tumors become resistant to platinum, they develop all sorts of mechanisms that helps them live through a lot of the things that we use. So it's been a hard place to develop, but I do think we're getting better. The biggest, I think probably the belle of the ball or Cinderella story is antibody drug conjugates. These work well in this space. So I've already told you about one, that was Elahere. Let me just show you a little bit backwards how they work. So these, you kind of think of them like a Trojan horse. They're antibodies. They target a tumor antigen. That's a protein on the surface of a cancer cell. That protein should be either only on the cancer cell or so overexpressed on the cancer cell relative to normal cells that this drug only goes to cancer cells. You don't want this drug sticking to a normal cell, or it's going to deliver chemo to that. So it's a tumor-specific protein. It's got these linkers that are very elegant that hold a drug payload on it while it's in circulation, so it's inactive. And the drug payload is a chemo, and there's actually even more drug payloads being developed that are like immunotherapy too. Those are coming, but right now they're all chemos. And the chemo is highly, highly, highly potent chemo. It's not Doxil or topotecan or gemcitabine. It's really potent. You can't give it as free drug to you. It will kill your cancer, but it would also cause so much toxicity that would harm you. But if you put kind of nanomolar or picomolar levels of this on these conjugates, then it's in your circulation, it's inactive. It finds its target. So you can see that here, binds to its target. The target thinks it's a friend and gives it this hug, brings it inside the cell, and then it undergoes something called endocytosis, where it breaks it down and releases those payloads of chemo into the cancer cell. And so it should kill the cancer cell. And then as the cancer cell dies, it escapes through the cell membrane and will kill surrounding cancer cells, even if they don't have that protein. That's called bystander effect. That's how Elahere works, targets folate receptor alpha, and it carries a payload on it that's, I guess, most similar to paclitaxel. It's a microtubule toxin, but it's not paclitaxel. So patients have had paclitaxel, still respond really well. These are new chemos. You're not resistant. The tumor cells shouldn't be resistant to them because of prior exposure at this point. There's a bunch of these in clinical trials, and many of them have already shown very early efficacy. These are the three leading targets right now. And I don't have time to show you all the things in clinical trials. Folate receptor alpha, mirvetuximab is approved, or Elahere. These two, luveltamab and farletuzumab, acertebulin, they're hard to say, are in later phase clinical trials. And I'm going to show you the CDH6 and HER2. But we're already like third generation for folate. So Elahere is here, yay, getting it globally activated. There's already third generation drugs in phase 1 clinical trials that are seeking to do better than mirvetuximab. Just so you know, we don't have to go into these, but we're already going to eclipse that. You know, in 5 years from now, we're going to have a new folate receptor alpha drug, maybe 6 or 7, but they're already coming. So this is a great target. It's going to have different payloads, more affinity for folate low. These are coming. So we don't stop with a new drug. We don't just go, oh, good, here's Elahere, we're done with folate. Nope. What's the next generation? Let's get it going. So these are already in clinical trials. A new target is cadherin-6 or CDH6. This is a hard drug to say. It's called raludotatug deruxtecan. Hopefully it will have an easier name at some point. But this is another antibody drug conjugate. It targets CDH6, which is highly overexpressed on ovary cancer. And it has a totally different chemo on its tail. We just presented data at the European Society of Medical Oncology last week, actually 4 days ago, on this medicine in 60 patients. And we're about 50% response rate. But you can see, because I taught you about waterfall plots, that most patients have downward waterfalls. This is what we want to see. So most patients who participated in this clinical trial were helped. This is currently my favorite clinical trial. This is moving into a big phase 3 trial to get it FDA approved momentarily. This is coming. And it's been very well tolerated, I will say. So this is probably one of our more promising agents, as is trastuzumab deruxtecan. This is another antibody drug conjugate. targets HER2, which is a breast cancer marker, but we find it elevated to some degree in about 30% of high-grade serous ovarian cancer. Most are low expression, but it's there. And then, like 19% are low, and then 11% are 2+, 3+. Breast cancer literature, though, tells us this drug works in 1+. And so this was moved into a clinical trial called Destiny Pan-Tumor, which evaluated it in a variety of cancers, including ovary cancer. And in ovary cancer, you can see the data in red. And if there were 3+, like a lot of HER2, kind of like folate receptor alpha high, like HER2 high, the response rate's 64%, like pretty phenomenal. But it's still pretty darn good in HER2 1+ and 2+. So this is moving into clinical trials. I can't tell you about them quite yet because it's not in public domain, but these are quickly moving into clinical trials so that we can get these available. But we're starting to test all of our patients with ovary cancer retrospectively even. Even if they've already had testing, I'm resending it. We're all sending it for HER2 so we can see who might get this. So those are antibody-drug conjugates, and there's a whole bunch of them in development right now. The other thing that's in development is a class of drugs trying to target what we call replication stress. If you remember back to that picture of PARP inhibitors I showed you at the beginning, how PARP inhibitors cause more DNA damage, and then there's that replication fork that kind of falls apart, and then the cell dies. Once tumors become resistant to PARP inhibitors, which they do when you treat them with PARP inhibitors, and they progress on a PARP inhibitor, and we can't use that anymore. But we can still target that replication fork and try to make it under so much pressure that it's like having to go so fast that it can't keep up with all the errors it's making, and it dies. So you just basically cause what we call replication fork stress. You stress out the replication fork. And there's medicines that do this, and they're called ATR inhibitors and WEE1 kinase inhibitors, CHEK1/2 inhibitors. There's a bunch of these. And these are all in clinical trials right now, mainly in the platinum-resistant setting. And they're mostly in combination with gemcitabine, which is a chemo that in and of itself causes replication stress. So we're trying to build upon that with new drugs. So these are all in kind of earlier phase studies, phase 1, 2, but early signals of efficacy. So I'm pretty excited about this class of drugs. So you might see these at your institution. The reason that those studies, one of those studies, actually, I'll go back for a moment, the one on the far right here, and even this one in the middle, azenosertib, which is a WEE1 kinase, and the one on the right, which is a CHEK1/2 inhibitor, prexasertib. These are in largely biomarker selected populations, and we're still working on the biomarkers. They're not validated yet. There's a lot of things we're looking at. Cyclin E, there's a number of these things. And they require, like this prexasertib study requires a new biopsy at a time that we want to come on to look for these biomarkers, because we're understanding more and more that these tumors change over time and with exposure to all these medicines. And so we don't want to use a medicine based on archival, like your first diagnosis might have been 5 years ago or 4 years ago, based on that tumor, because the disease may be different now. So we're really trying to, which is uncomfortable for patients to get biopsies, but the reason we do that is so we can really understand what's happening in the tumor at the time that you need something, and probably pick better drugs. We're not there yet, but we're getting there. And that's important because of this. This is the sad story. So these are 3 big clinical trials that just resulted this year. All of them with weekly paclitaxel as a backbone, because it's a good regimen to use in a platinum-resistant setting, adding a new drug, an exciting new drug. All 3 of these were exciting. All 3 of these were negative, every single one of them. Not one signal of benefit when we added a new drug in an all-comer population to paclitaxel. And it may just be that paclitaxel is the most effective drug in this space and it's hard to improve on. But it's probably more likely that when we just do these big studies indiscriminately without trying to really select who's going to benefit from this new drug, we're going to continue to see these negative trials and maybe throw out drugs that are quite interesting, but maybe for a smaller population. So we're really trying to focus now more on biomarker development, and enrolling clinical trials for the patients we think are most likely to benefit, so we can get better results. But it does make trials more finicky because we're asking patients to get biopsies, which no one wants to do. And I understand that, but that's the reason why, because we're just throwing things at a bunch of, 1,000 patients without selection is unlikely to work. And I think that's what we're learning moving forward. And we're certainly going to learn that here with immunotherapy. So I'm just going to finish my talk talking a little bit about immunotherapy. So a lot of my patients come in and they're like, why can't I have Keytruda? Because the commercials say it's my chance to live longer. Well, that might be Opdivo. Same drugs. They're just different companies. These are immune checkpoint inhibitors. And they are indeed miraculous for some patients with lung cancer, bladder cancer, melanoma, others. They have not been miraculous for ovary. Why is that? Well, every cancer has a different interaction with what we call the cancer immunity cycle, which you can see on the left. This is if you start at number 1, this is sort of what has to happen for your immune system to recognize that the cancer's there is bad and mount an immune response by making programmed T cells that are there to kill the cancer. I mean, that's what should happen with your immune system so you don't get cancer. You should recognize this thing is foreign and kill it before it becomes a cancer. Some cancers interact with the immune cycle, like melanoma or lung. They really, at cycle 1, they release a lot of proteins in the circulation. The immune system picks up some of those proteins, carries them to a lymph node and says, hey, take a look at this. Should we kill it? And the lymph node's like, yeah, I'm going to create some T cells to kill this protein, anything that expresses this protein. I'm going to send these T cells through the blood vessel back to the tumor, and they're going to kill the tumor. Ideal. Ovary cancer doesn't do this. It doesn't release a lot of antigens into the circulation that elicit an immune response for a variety of ways. And so you have to have that immune response present in order for drugs like Keytruda and Opdivo to work, because basically they work by unmasking the tumor from an activated immune system. So the immune system's like they're looking for the cancer cells to kill and it can't find them because the cancer cell sort of cloaked itself. Keytruda works by opening that back up so the immune system can work. If the immune system's not activated against the cancer, those drugs have no effect. They don't stimulate the immune system. What we need to do is stimulate the immune system or just create a external kind of immune system and give it back to you potentially. And that's what we're working on with these strategies. So immune checkpoint inhibitors are here. That's what I was just talking about. Keytruda, Opdivo, Imfinzi, all those drugs. Probably not super effective, but we're still studying them. Adoptive cell therapies are things like CAR T and engineered T cells. So I'll show you an example of that. We're still looking at vaccines, cancer vaccines. Those are a bit tougher. And then oncolytic viruses, we have one of those in clinical trials. There's just a lot of different ways these work. So if you wonder about how do vaccines work and why have they been tough in any cancer, really, why can't we just vaccinate you to prevent cancer? Why can't we vaccinate you so your immune system revs up and starts fighting the cancer cells like it does, a bacterial infection? And so really the point is we have to give you a vaccine that gets enough of an immune cell response kind of revved up to fight the cancer. And in cancer cells that have all these different proteins on their surface, if you're creating a vaccine that targets just one protein, that may not be enough to really get enough of an immune cell revved up, although people are looking at this. Oncolytic viruses are these viruses that we've modulated with different sorts of gene signatures that should generate what we call immunogenic cell death. So I'll show you an example of that. CAR T cells or engineered T cells over here, we basically manufacture like 10 billion cells for you that are targeting a specific protein, on the surface of cancer cells, and then we infuse them back into you. So we give you an externally generated immune response, and rather than asking your body to create it. And that's like a standard of care therapy for leukemias and works really well. The question is, can it work in solid tumors like ovary? And then we've talked about immune checkpoint blockade already a little bit. I'm going to skip that. So just because I've sounded kind of negative about immune checkpoint blockade, like Keytruda and Opdivo, et cetera, doesn't mean we haven't studied it. There are 3 big studies that are going to start reading out any day now in the platinum-resistant setting of chemo plus an immune checkpoint inhibitor with or without bevacizumab. Some of them had bevacizumab required and some didn't. The one on the right-hand side is going to read out next week at the International Gynecologic Cancer Society meeting by Dr. O'Carroll, and the other 2 will probably be 2024. So maybe we'll see something here. We'll see. But these studies are done, mature, and we're going to see them starting to read out. Novel ideas are these. I'm going to show you kind of 3 examples of things that are next generation immune interventions. This is a very interesting study. It's in phase, and I'm showing you the things that are in phase 2 or phase 3, so later phase clinical trials, not really phase 1. This is a phase 3 study called Artistry 7. And basically it looks at what's called, it's a modified interleukin 2. So high dose interleukin 2 is an immune therapy. And we've used it in the past for melanoma, like when I was a younger person. It's really toxic, but you basically just give someone this big blast of interleukins, and it just can clear the cancer cell, but it causes like lots of side effects. It can make your vessels leaky. So patients will get this like capillary leak syndrome. And also it can stimulate the bad immune system cells, which are called Tregs, T regulatory cells. Those are immunosuppressive. So it's like this indiscriminate stimulant of the immune system, and it can stimulate good cells that will fight your cancer as well as bad cells that could suppress your immune system and make your cancer grow. So you can get these, kind of schizophrenic responses. So this is a modified IL-2 receptor agonist that just hits the good cells. So stimulates the good cells, which are these CD8 T cells. These are your fighter jets and natural killer cells. And it does not hit those regulatory cells that are immunosuppressive. And it has like none of those bad side effects, like the cytokine release syndrome. The phase 1 waterfall plot I'm showing you on the left-hand side, small numbers, but looked pretty promising. So this has moved into a big phase 3 study of the drug, which is called nemvaleukin, hard to say, plus Keytruda. The main comparison is that combination versus chemo. So arm 1 versus arm 4 in that middle figure. But the FDA makes us sort out the relative contributions of each thing. And so there's a nemvaleukin alone and a Keytruda alone arm that don't accrue as many patients. So you can see the randomization is 3 to 1 to 1 to 3. So for every 3 patients, well, I guess every 11 patients, 3 go on arm 1, 3 go on arm 4, which is our main comparison, and only 1 go on each of those monotherapy arms, trying to minimize patient exposure to what we would consider less effective drugs. So this is pretty exciting, new, and accruing quite well in the US right now, but still accruing. This is adoptive cell therapy. Like it's not CAR T, but it's like CAR T, where we are creating T cells for a patient. So in this study, we have to screen someone's blood for what's called HLA. HLA is a protein that presents foreign proteins to the immune environment. And so you have to have a certain HLA to come on this study. It's about 50% of Caucasians will have HLA-201, about 30-ish% of Black people, about 18%, depending on where in Asia someone may come from. But you have to have HLA-0201 or 0202 or 3 or 6. That's a blood test. Then we test your tumor for a protein called MAGE-A4. If you have both of those, then you're eligible for this clinical trial, which basically we make, 2 to 10 billion programmed T cells out of some circulating blood from you, where we'll find some of your T cells, they engineer them to hit MAGE-A4 and then make 1 billion of them. And then we give them back to you with or without immune checkpoint inhibitor. So this is a randomized phase 2 study that is accruing now, just opened. So lots of spots on this one In the phase 2-ish study that we did, the response rate was about 42%. Small numbers, highly selected, but encouraging. And then for, we talked about just vaccinia viruses. This is another exciting, completely different product. But this is a modified oncolytic virus that basically aims to activate your innate immune response to tumors along with chemotherapy. So this went through a phase 1 study in pretty resistant tumors. Like a lot of these tumors had really blown through platinum initially. Small numbers again, this is only about 30 patients, but the response rates were pretty darn good. And here's what we call the waterfall plot. You can see on the right, small numbers, but a lot of patients seem to benefit from this. So it's interesting, and this is why I told you about platinum earlier, that even when a tumor is considered platinum resistant, sometimes we use platinum again. This may be one of those spaces where it makes sense. So this is a big phase 3 study that randomizes patients with platinum-resistant ovary cancer for whom platinum would still potentially make sense. So it's not everybody, but some, and they get platinum, or they get this oncolytic virus intraperitoneal. So it's given where the tumor is, followed by platinum. And then they're looking at outcomes. So, all 3 of these studies I just showed you are not appropriate for all people. They're appropriate for some people. And we have to start individualizing best, rather than just throwing the same thing at every person and expecting it to be successful. So these are all exciting. There's many other options out there. So this is a area of high unmet need. Trials are key. And really key for us to continue to develop biomarkers so we can make sure we're individualizing to patients as best we can. And honestly, the best way we do this is by screening and prevention, which we're working on so that hopefully in the future, people don't have to get this disease. But that's a bit out. So until then, we're going to continue to do trials. And with that, I thank you for your attention, and I hope this was helpful. Bye.